last question we are going to take for today is from India. So he's saying, in case I have sacral osteophytes, what shall I do? Sacral osteophytes. Sacral osteophytes.
Gabor,
sacral osteophytes.
Osteophytes, neuroplasty. I had neuroplasty, but one thing you have to do, because you have an altered perception in the area where the osteophyte is, but the scar tissue surrounds the nerve, and because the nerve swells up, and the hyaluronidase prevents neutrophil infiltration. And there are 2 papers on that. And when the swelling doesn't happen after your procedure, and that's why you have 2-3 days of pain after epidural steroids, because before the anti-inflammatory effect kicks in, you get edema formation and pain, depending how much room you have. But if you use hyaluronidase before, and the patient can afford it, or then you don't have the post-procedure pain. So, and the other thing is that you need to do a pain drawing by the patient, where crisscross for sharp pain, crisscross or dots for numbness, or touch me not pain, the allodynia. Because I remember when I thought of this idea, but we never published it, that when I saw the patient about a month later, and she says, oh, no difference, it's the same pain. So I said, is that tender? Said, oh no, that doesn't hurt. So you need evidence that's filled out by the patient, because neuroplasty works. Hyaluronidase increases spreading, and the hypertonic saline disconnects C fibers. And there is no post-procedure worsening, but you must not do that with hypertonic if you have immediate post-injection numbness, big block, because you are subdural or subarachnoid. And if you don't follow the instructions that we figured out, we can now do pain-free hypertonic saline injection. And the trick that I accidentally learned, that we don't use the hypertonic saline mixed by the pharmacy, because they just dilute it with saline. And we use 23.4% vascular corrosive they use for veins, and I dilute that 6 cc's of 1% lidocaine, 4 cc's of 23.4% hypertonic, the 23.4% hypertonic, 6 and 4, and that comes up to 9-point-some%. I call it 10%, but it's not above 10%. We have good safety data on the hypertonic. There's not a neurolytic. There's only one man who is misguided and misled an awful lot of people, Berkemeyer, who says, I was lecturing in one room and I got a big award in South Korea. And in the other room, he says, don't use it, it's neurolytic. No, we studied in the first edition, before we did anything, we studied that hypertonic is not a neurolytic. We did compound action potential studies. And in 30 minutes, the nerve recovers. It is like a local anesthetic. And when you mix local and hypertonic, you need observation. And if you are subdural, or you are still have a reason to have a motor block, I've been an expert witness in 2 cases of deaths where the patients had cardiac arrest because they were getting so much better after the procedure. They were getting dressed to go home, and when they opened the door, the curtains, the patient died. For the sake of privacy, don't close the curtains on the patients getting dressed. They need to be observed. And first time when you use 0.25% Marcaine or 0.2% ropivacaine, you get additive effect motor block. You get 4 hours of observation requirement before they can stand up. Where is my 4 hours coming from? Because that's what the patient told me, that short of 4 hours and we let them go, the knees buckle and you can fall down on your knees and you smash your kneecap. And it's not nice. So by switching to 1/8% for the final, in the second and the third injection, they recover in about 40 minutes. 30 minutes is the separation, of 40, 45. Well, but it takes about an hour or an hour and 15 minutes. You can let them go. But they have to walk to the bathroom, void, and they can do that. Void urine, and no problems. So far, remember though, there are outliers. You have to be careful, but these are the things I've learned, you know, even though I'm younger than you are.
Yes, definitely you are. I have no doubt.
In my mind, not really, you know, really watch out for older people, watch out for hypertensive, dehydrated people. You have to be a doctor, you know. It's not something you can do with reckless abandonment. Well, I don't have any problems. If I had problems, having done 157, and you know how irritating it is to neurosurgeons when out of country, never mind out of town, and just a low down anesthesiologist coming in to teach them why they have failed, you know. They wanted me to fail to deep down, you know. It was irritating. And when I said to that professor that I'm not doing that one, there was a lady who had multiple neck surgeries and several curves in her neck, and I could not see any spinal fluid on the MRI. And I said, I'm not doing that one. That's the only case I said no to. And that's the only thing I'm teaching you, that don't do it when there's no spinal fluid. Do it below and watch it and see it. Then you go higher and higher. Don't do any cases of arachnoiditis. We published in the first 116 case study. It was just a retrospective look. And don't do, and we published a lady who was saying she's not in pain, she's grateful, did not have a lawsuit out of it. And she says, I was bedridden before, and at least I'm not in pain. And but that was the only one that I had. And don't do any syrinx cases. Because I was an expert witness in a case where the doctor was asked to put in a stimulator because that helps. But from the loss of resistance technique, the patient got paralyzed. So his friend now was turning on him for help doing a procedure on the parent, so syrinxes, until you get to be my level, it will take you a few years.
Lifetime. It will take a lifetime.
I went in, starting from the caudal epidural space, there was a low cervical syrinx. And I opened up all the way and then put a stimulator from below up to that level, just above the level. And it worked for several years. But
thanks a lot, my dear professor, for all your invaluable teaching and for all those years you have been teaching us, and for this amazing lecture. And actually, people worldwide who attended, whether through the Zoom meeting or whether live on Facebook, are thanking you for your time and your valuable information. Thank you very, very much for...
Thank you for being so good a teacher, because you are a teacher. You can't suppress it. And all these doctors are teachers. And one of my message in that article I mentioned, collegial communications, is that if and when you get into trouble, don't be alone out there. Figure out who is the best person that you can reach on the telephone, who will come and help you. And you must be willing and able to help anybody and everybody. And we need to build a network of people that we help each other. And you have no idea how many times it happened to me. This is one that most people don't know about. The other one is they don't know about ionized versus non-ionized contrast media. So if you have injected, one of them was my friend, calls me from 3,000 miles away. He says, I changed a subarachnoid morphine pump line. At the end, I injected the catheter to the pump to be sure that I'm in the subarachnoid space. And about 20 minutes later, by the way, you will not see this described, so better, those of you who are still around. And patients started twitching. I said, don't argue, go back, get you some preservative-free saline and three-way stopcock and irrigate the subarachnoid space out. And the issue is, don't quiz the nurses who did what, but that's so sure. And the patient survived, went through renal shutdown, but survived, eventually did very well. And they found out that the nurses instead of giving omnipaque, they changed the head nurse. So those doctors don't know anything, you know, stupid. They replaced the omnipaque with cheaper rhinographin. And another one was hypaque, because you are given a syringe and you can't tell because it looks like water. And when you inject, twitching, seizure-like activity, hypertension, blood pressure high, and the only solution is you have to rinse it out. You put it in, you get it out. That was not your intention to kill the patient. So both of these patients, the doctors called me. I said, don't argue, go and rinse it out. And how do I know about this? Because if you read the package insert for hypaque, it will state it can cause cord injury, damage, and the companies put it in, so it shift the blame onto you. And so nothing is totally safe, but it's not likely directly in every patient cause problems. So that's one. The other one is inevitably continuous pain and weakness. One doctor, friend of mine, great guy, I learned other things, a neurologist and doing neuroplasty, and he said, I just injected 30 cc's of lidocaine and pain is worse. So what do you think? Anybody on the audience? See if I teach you something. The pain is worse after lidocaine. 30 cc's he injected. And then I told him what to do. And I got a one word response on the messages. What was it?
Check for the toxicity.
No, he says, fantastic.
Fantastic.
Pain went. Well, what did I tell him? I didn't say. I asked, well, what did he say to me? He says, fantastic. Pain went instantly. But what did I tell him? I told you guys the same bloody thing. And all right, I'll, while you are thinking, flexion, rotation. I thought I explained to you, if you are epidural space, and he used the catheter, compress the blood supply to the spinal cord, and you open up lateral runoff of the veins, but also of the fluid, the 30 cc's. It leaked out of the epidural space, because when you do this, look at the neural foramen around that one, you know, it gets bigger.
Yes.
You know, when you bend forward and touch one leg, one opposite hand, another one, and then keep doing until the strength gets better. I told you a story of I forget now. you guys drained me. There was something else about flexion rotation, because when you do a neuroplasty and the pain continues, you have to do the flexion rotation. And if it is subdural, you need to look on the lateral view. And I think there is a subdural picture. You put a needle in because it looks like clear fluid in the middle and the sausage on the outside, the contrast in the subdural space, but that compresses it. And the patient has bilateral leg pain if it's subdural, and in the neck, they die. What did I tell you? You know, if you're subdural, they may stop breathing later because you get a motor blood. And all of these complications are present with every procedure, because just because you haven't had any problems, it doesn't mean the problems are not there waiting to bite you. Any needle stick, I think I mentioned a patient that became quadriplegic from a transforaminal sharp needle injection, small volume, quadriplegic, after 3 years of being totally immobile. He says, take me off. I don't want to live like this the rest of my life. Took him off, young man.
Thanks a lot, my dear professor. You are such a living legend. We can't thank you enough for all this information and all your time you are giving for teaching doctors, not just from the United States, but from all over the globe, actually. So thank you very much for allowing us to have this live class. And also, I'd like to thank all our participants from all over the world who have been watching us, whether on the Zoom or whether live on Facebook. Thank you all very much, and hope to see you in upcoming meetings with all the topics you want to learn about. Thank you very much, my dearest professor. Thank you. Bye-bye.
How many people are still watching?
I believe on Facebook, we have about 25. And we have some on Zoom going on and off.
It's because of watching you, you know, that's why.
No, it's because of watching the legend. Because of watching the legend. Actually, we have doctors from almost every part of the world. We have from Romania, from Turkey, from India, from Pakistan, from Saudi Arabia, from Egypt.
In Pakistan, I did procedures.
Ah.
And there was a lovely story there. And we were, you know, hurried to this procedure area. And this Pakistani doctor was dressed in gown and mask, so I couldn't recognize anybody. And he was moving so smoothly, and you know, everything was clockwork, you know, beautiful. And I was saying exactly that. Now this doctor is so good and so smooth, instead of going you know. A miracle is that everybody doesn't die. And then the doctor came out to the audience. It's a big room full of people. And I said all this kind work. And then when he came out, it turned out he was one of my ex-fellows, a Pakistani.
Oh.
No wonder he was good, you know? I mean, you can tell when...
Because you have learned from the best.
Soft, and you are concerned about causing complications. And would I tell you that this is the way to do it and it's not so, I don't do it myself? I do everything just exactly what I'm saying.
Thank you very much, my dearest professor, and we can schedule further live series for doctors because they have been enjoying it very much.
Let's do headache next time because that's amazing.
Okay. Let me schedule headache.
And it's
okay, that sounds great. Thank you very much.
right, you are.
Thank you. Bye.